Yeah.
Okay. Good evening and welcome to the Sherwood B. Winslow MD lectureship virtually. I am Brenda Hunt, President and CEO of the Battle Creek Community Foundation. I'm pleased that we are able to gather this evening to conduct the lectureship. Special appreciation to all of our guests, speakers, and especially to Angela Stewart, the Community Initiatives Officer at the Battle Creek Community Foundation for Population Health Alliance, who organized tonight's lectureship. The Winslow lectureships have a history of being relevant. Tonight's topic is likely to be the most relevant and timely in our history. I'm very confident that Norm Williamson, who established the Sherwood B. Winslow MD Lectureship Fund in honor of his friend and local physician, Dr. Sherwood B. Winslow, is especially pleased with the flexibility and relevance of the lectureship this year. We have some other important details and items to address this evening prior to beginning the lectureship. First, I want to acknowledge the passing of a local civic leader, attorney, friend, and a real icon in our community, especially when it comes to progressive healthcare delivery and hospital mergers. The late Chris T. Christ, who passed away last night. Let's pause to reflect on Chris' legacy, a life well lived. Now, as we begin our program this evening, I am very pleased to introduce Bill Winslow, Dr. Sherwood's son, to present another tradition, the Dale G. Griffin Healthcare Leadership Award. Bill?
Yeah, thank you, Brenda. This is a real honor. I mean, I was a friend of Dale Griffin's, and his wife Kathy and his kids and my kids played soccer together, so it's a nice legacy. Anyway, the Dale G. Griffin Healthcare Leadership Award was created to honor the many contributions of longtime healthcare trustee and community volunteer Dale Griffin, who passed away in 2001. A committee of healthcare leaders has selected Eric Stewart, he's got a smile on his face, Eric Stewart, as the 2020 Dale G. Griffin Healthcare Leadership Award. Did your wife tell you about it?
No, as a matter of fact, she told me it was someone else. So there's a little deception there. And thank you very much. That's shocking to me.
Good for Angela.
I appreciate that. Thank you.
Eric has been a driving force behind several influential projects. Stewart Industries launched a medical supply division in order to fight price gouging that was so common in the PPE industry at the start of the pandemic. While other companies were trying to make as much money as possible off of their masks, Eric and his team were finding ways to provide reliable protection at affordable prices. Eric's efforts didn't stop there. Through Stewart Industries, Eric helped develop a back to it kit designed specifically for classroom environments. He and his team reached out to school districts both in Michigan and across the nation to find ways to help equip them with PPE that they needed to keep students, faculty, teachers, and the staffs during face-to-face lessons, keep them safe. When it became obvious there was a need for PPE closer to home, Eric stepped up to help. Stewart Medical Supply is actively working with the Healthy Battle Creek Initiative to provide PPE to the Black community in Battle Creek's Washington Heights neighborhood. This work will provide 1,200 PPE resource kits to at-risk individuals before Thanksgiving in an effort to prevent a super spreading event. All these kits are provided to the healthcare Battle Creek from Stewart well below cost. And the kits are free for community members. Eric has been in his community well before the COVID-19 pandemic hit this year. He spent years of service with Bronson Health and has volunteered to help Battle Creek win the 2019 All-American City Competition. Eric is the current board chair of Community Partners, and he serves on the Bronson Healthcare Group Community Health Committee. He's also on the Bronson Cancer Care Campaign Advisory Committee. And I'm really happy to present this to Eric. And by the way, his father won this a few years ago. Yes, that's right. So congratulations, Eric.
Thank you, Bill. Thank you. I appreciate it. I'm glad I wore a bow tie tonight. That's not why, though. But okay. I was trying to impress my wife, but this is good too.
I'm gonna turn this back over to Angela, your wife.
All right. Well, thank you, Bill, and congratulations. But now I'm going to turn it over to Eric Stewart to actually introduce our first speaker for tonight.
Look at that, back to work. Thank you all. I'm honored and I'm appreciative. But like I said, now it's time for me to get to work. And the good thing about it is I'm honored to be here tonight to support the Dr. Sherman Winslow Distinguished Lectureship. But it's important to know that at Bronson Battle Creek, we strive to support health, well-being, access to care, and growth for our region through excellent care, regardless of who you are or where you come from. It's what Bronson positivity is all about. Part of that care continuum is supported by Bronson team members, such as my friend, Dr. Lane Davies, who grew up as a local kid here in Michigan with deep roots to Kalamazoo region and Bronson. Previously as medical director for Bronson Children's Hospital and chief of staff of Bronson Methodist proper, he has been a focused advocate for those values that make Bronson an award-winning hospital and one of the best in the region. His current position is Chief of Quality for the Bronson Medical Group, and as you may have very well assumed, with the recent acceleration of COVID, he has his hands full as of late. Hence, for us at Bronson, he is one of our go-to specialists to make sure that as an organization, we are at the tip of the spear when it comes to battling COVID, its growth, and its effects on our community and our most vulnerable populations. With that being said, please welcome Dr. Aaron Lane Davies to discuss the recent trends and disparities around COVID-19 in Southwest Michigan.
Thank you, Eric. All right, Angela, can you just confirm that you're seeing my screen okay?
Looks good.
All right, thanks. All right, well, thank you, Eric, both for your kind words and congratulations on the well-deserved recognition for all the work that you've been doing in our communities. I'd also like to thank the Population Health Alliance and the Battle Creek Community Foundation for this opportunity. So we're going to take you through really a local view of COVID, both in terms of its impact and the things that our communities are doing to help ensure the safety of all of our friends and neighbors. We're going to talk about a few of the basics of COVID-19. I'm going to use the term "the best data suggests" a number of times during this presentation, and I do that to help to make sure that we understand that sometimes we have good information to help lead us, and sometimes the quality of that information is not very good. And I will try and provide some clarity about which of those buckets things fall in as I talk through the COVID situation here in Southwest Michigan. We'll look at the trends through the pandemic time. We'll talk about our overall COVID rates, the positivity rate, mortality, approaches to keeping healthcare teams and patients safe through our perioperative testing process, as well as hospitalizations. then we'll spend some time talking about the disparities that we've seen in COVID, both at the national level and here in Southwest Michigan, and try and contextualize that with other disparities that we see with other disease processes. So just a really brief overview. COVID is caused by a virus in the coronavirus family. Coronaviruses cause all sorts of disease, predominantly respiratory disease that can range from mild to severe. The virus is the severe acute respiratory syndrome associated coronavirus 2 or SARS-CoV-2, and COVID-19 is the disease that's caused by the virus. This virus most likely has a zoonotic origin, meaning that it evolved in an animal species and then mutated to be able to transmit to humans. This is similar to the probable source of several influenza strains as well as Ebola. So we've made really amazing progress in care standardization over the past 20 years in healthcare, and this has really come as a result of coordinated efforts through organizations like the Institute for Healthcare Improvement, as well as many others. And we've seen the impact of that quality improvement and the utilization of the strategies that we've learned from these organizations as we've worked to treat and care for people with COVID here in Southwest Michigan. We've seen a decrease in our number of ICU admissions and a decrease in our mortality as we move into this second wave of significant COVID here in our communities. I'll start off my presentation this evening with a quote from Don Berwick. Dr. Berwick is a fellow pediatrician and was the leader of the Institute for Healthcare Improvement for about 25 years. And in the early 1990s, he was reflecting on the early part of their journey in healthcare. And he said at one of his keynotes, how far we've come. A mere 5 or 6 years ago, the language of quality improvement, if not the ideas themselves, would have met with blank stares in most quarters of American healthcare. It's not that we don't believe that improvement was necessary, but rather, simply put, we didn't have a plan. As we talk about, as I reflect on the COVID data that we have, would just really highlight that when we started this journey, the sources of data and our ability to see utilizing this data was very limited. Myself and other members of our team were daily, plugging the little bits of information that we could glean from the state and from our own internal mechanisms into Excel spreadsheets and trying to make sense of the early data. That has evolved remarkably over the last 8 or 9 months, and now there are multiple sites with really robust data sets that help us to better see. An important part of that improvement has been the ability to stratify both our data and at the regional, state, and national level, other data sets by race and other important social demographic categories. But also highlight the importance of really creating a data infrastructure to help us measure and then take action on things that are important. And we've certainly made great strides in that area as we think about the care and prevention of COVID-19 in our communities. Throughout my presentation, the majority of the data that I'll be sharing is from within the Bronson system, and I will identify when we're incorporating other data sets. So this graph represents the positive COVID results here in the Bronson system. The data on this slide reflects the first 6 months of the pandemic here in Southwest Michigan. I show you this slide to demonstrate that there were some peaks and valleys as various interventions came into place and as our ability to test at scale increased to meet the need of the community. And I showed that slide first because when we look at the whole period of the pandemic from the end of March until the current day, those early peaks get lost in our most recent number of cases in the community. So really since the late September, early October, we've been in a very rapid growth phase, and that's demonstrated by the dark green line. The light green represents the peaks and valleys of day-to-day testing, and the dark green line is a rolling average over 7 days, so that you can see the trends more consistently. And this data includes testing from all of our sites, including partners in the community in the inpatient and outpatient setting, and our system regional emergency departments. A really important metric in terms of how well we are doing with both testing and with control of the virus in the community is the number of tests that are positive out of a particular sample. And when we started back in early March or late March and early April, the positive rate was between 10 and 15%, with the peak being in late April. This is a little bit deceptive when comparing to our current time, because our testing supplies were quite limited in this period. And so we were predominantly testing only people who were symptomatic and had more serious disease. As we began to build our supply chain and processes to ensure that we had adequate access to testing supplies, that process was occurring through the late spring and early to the summer. By the time we got to midsummer, late June, early July, we really had the testing capacity that we needed to meet the needs based on the priorities set forward in the state and by the CDC. The low point in our positivity rate was in early August, where only 2.5% of people being tested were coming back positive. And as you can see from the graph, there was a long period between early summer and early autumn where the rate was relatively stable and relatively low, certainly less than 5%. Beginning in late September, we've seen this very steady rise, not only with the number of cases, as we've talked about on the previous slide, but also in the positive rate. And so currently we are at or near our peak that we've had since the beginning of the entire pandemic, with just a few days ago, nearly 20% of people being tested in our system were coming back positive. And this data is complete through today. As Brenda alluded to in the introduction, the data is changing very rapidly, and what you're seeing today represents data that is as recent as midnight tonight. So, another really important metric of not only the impact of COVID in our community, but also that impacts our ability to care for patients in the region outside of the COVID epidemic is our inpatient volumes. The blue line represents the current inpatients across the entire Bronson system, and the red line represents our ICU care. Several interesting highlights about this data. Through much of the pandemic, starting way back in April and late March, the percentage of patients in the ICU was relatively consistent, ranging anywhere from 30 to 50% and even a bit higher at times. And that, as I say, has been very consistent. We see a divergence in that starting in early October, when the total number of hospitalized patients began to rise very dramatically. However, our ICU capacity and ICU hospitalization rates have remained relatively flat or slightly increased. Coming back to the comments that I made about Dr. Berwick and the importance of care standardization, I hope that we made good use of the time between April and October, and I think that this data demonstrates that we did. We spent a tremendous amount of time learning from both our own experience and the experience of other healthcare systems around the world, collaborating with other institutions and therapeutic trials to understand what works and what works better for the care of COVID patients. And this slide is a nice demonstration of the importance of rapid learning, learning quickly and testing and learning again. And then finally, creating a system and standardized approach so that the care that somebody is receiving in a regional emergency department or at any of the hospitals across our region is based on the most up-to-date evidence and is being implemented in a way that's consistent and reliable. Part of our approach to ensuring that we are keeping our team safe and also that we understand the extent of spread in the community has been our pre-surgical or pre-procedural testing for the virus that causes COVID-19. We began this first in July as we were getting back to providing outpatient and elective or less urgent care across our system. This was really the first widespread testing of asymptomatic people in our communities. And the goal was really to increase the safety of our teams and to understand the extent of COVID in our community. We were a bit more selective than some other institutions and continue to learn from this in terms of who was at the highest risk of transmitting and in what scenarios were those patients likely to put healthcare teams at risk. And procedures that generate aerosols or fine particles that may remain in the air based on data from the original SARS virus suggest that there are good strategies to help protect teams, but also make the optimal use of the PPE that's available and continues to be limited as we battle COVID across the country. This data represents our pre-procedure testing, and this again is in the context of percentage of positives. So out of 100 patients, how many tested positive. And starting in July, our rates were between 0.5 and 1%, really across all of the communities where we were predominantly seeing patients. And so the bars are broken out. Blue is Calhoun, red is Kalamazoo, green is Van Buren, and then the purple represents the system total. Through the summer, we saw, again, relatively flat, although Calhoun County had a consistently higher percentage of positive, asymptomatic positive patients in the Calhoun County area. And again, this is based on county of residence, not necessarily where the procedure or surgery was being performed. In October, those numbers really equalized, and then we've had a very dramatic increase in our pre-procedure testing positive percentage during the first 2 weeks in November. To translate the percentage into something that sort of helps me to contextualize the risk that is going on in our community based on our system pre-procedure positive testing rate and extrapolating that out to the larger population. Essentially 2.5% or a little more than 2.5% of people during the first 2 weeks in November in our region were walking around with COVID-19 and didn't know it. And so if you extrapolate that to the larger population, 1 in every 38 people that you ran into at the grocery store, if you're at a large family gathering or at some other event, was statistically infected with COVID-19 and had the risk of transmitting that disease, but had no idea because they were asymptomatic. We've seen over the course of the pandemic here in Southwest Michigan, but also throughout the state, that the best data suggests that social distancing is really the most effective way of preventing the spread of COVID-19. There are a number of other strategies, and I look forward to hearing Dr. Goh's discussion of these. But foundationally, it is our ability to slow the spread of disease through social distancing that has demonstrated the greatest impact. Also, in the next couple of slides, talk about the interval between when an intervention occurs and when we see the results of that. And I'll give you the punchline now. The hint is that it takes between 2 and 4 weeks to see meaningful change in the case rates between an intervention and that outcome. Also talk a little bit about the differential mortality based on the spread of COVID-19 in the state of Michigan. Detroit was unfortunate enough because it's a large travel hub to be the city that was first impacted. And the time from when COVID began to spread in that community and meaningful social distancing interventions took place led to a significant disparity in mortality between Southeast and Southwest Michigan. And then just quickly highlight the new Michigan Department of Health and Human Services order that was released last night that refines our approach to social distancing in an attempt to limit the spread of COVID-19. So this is the graph that you've seen before with the total positive cases, and I've overlaid on this graph the meaningful social distancing interventions. So back in at the last part of March, March 24th to be exact, the governor issued a stay home, stay safe. The state really locked down very tightly during that period of time. But you can see it was nearly 2.5 or 3 weeks before we began to see a decline in the cases in our community, and similar trends existed in Southeast Michigan as well. On June 1st, that order was rescinded, and about 2 weeks later, we began to see a rise in cases again in our community and across the state. The executive order was revised, bars were closed, and there were several other social distancing interventions. And from that, we saw plateauing from that. And then the Supreme Court overruled the governor's ability to put in place executive orders, and the school year began all around the beginning of September. And it was again between 3 and 4 weeks before we saw the increase in cases in our community and across the state. Talked about the importance of timing. And so this is a very busy graph, but I will try and boil it down to what are the key points. And so the stay home, stay safe order from the governor occurred 6 days after there was sustained community spread in Southeast Michigan, but not until 4 days after the first case was identified here in Southwest Michigan. As we looked at the early part of the pandemic, over the first 100 days, if you compare the mortality in Southeast Michigan with Southwest Michigan, and more specifically, if you look at Calhoun County, the odds of dying in Southwest Michigan from COVID were only 18% of the odds of dying in Southeast Michigan. As a result, that was 125 fewer deaths in our region per 100,000. So that translated to 168 fewer deaths in Calhoun County than would have been expected had we had the same experience as Detroit and Southeast Michigan. I suspect many of the people on this lecture have seen this slide. This is the infographic from the Michigan Department of Health and Human Services talking about what's going to be open and what we're refining and dialing back on starting on Wednesday. Talked about the importance of good data sets and data architecture. We had a lot of time during the early pandemic to really get our data and analytics in order, and our team spent a lot of time making sure that we had the information readily accessible to better understand how COVID was impacting our community as we move forward. The next couple slides are small detail, but really just meant to represent the complexity of what we were able to accomplish. An important tool is to be able to look at the disease in particular populations. And so prior to COVID, we had made some small baby steps into being able to stratify in real time by important social demographics, including age, insurance status, race, and region, access to primary care. but this was our most robust step in that direction. And this slide is a detail that shows that essentially provider can or leader can in real time drill into a particular time frame, can look at a particular community, can stratify the data by race, age, class, and other important demographic features. And so having real-time data is really has been critical for us to understand how we have the greatest impact for our community. It's just a quick representation of our ability to look at where positive tests are occurring within the system, and again, to stratify that by whatever is meaningful to the person asking the question. An example of how we've used that is to understand the impact of COVID by age. The orange bars on this graph represent the distribution of age by positive case in April compared to the positive cases in October. In April, you can see the number of tests or the number of positive tests was much smaller. That was predominantly due to the lack of access to testing supplies. Would also highlight that the number of patients, number of pediatric patients that were tested positive in April in our system was 0, whereas in October, the pediatric patients were essentially proportional to the other age demographic. And this is important as we think about social distancing and attendance of children in school. We know that there are many health disparities in the United States. We see that in cardiovascular disease, we see it in infant mortality, and we've certainly seen it in COVID mortality. And foundationally, racism is what underpins these disparities. When we talk about racism, it's important to address, while it's important to address both implicit bias and individual prejudice. When I say racism, I'm really talking about the social and economic constructs that have exploited people of color, particularly African Americans in this country. So when we look at some of these local disparities, this is a trend of the ratio between white and Black infant mortality in Southwest Michigan. This is the example from Kalamazoo, and while we've made progress, Black infants are still nearly 3 times as likely to die than Black infants in our community. In Calhoun County, again, progress is being made, but in Calhoun County, Black infants are still twice as likely to die as white infants. When we look at the COVID mortality data, I'm going to talk about that in 2 different ways. One is the rate, so the number of deaths per 100,000 when we stratify that by race. This slide is one that I worked with our team and presented back early in the pandemic. And this was data through May of 2020. The comparison groups in here are a little bit atypical in that we were really just looking for anybody who was presenting this data. And so the Kalamazoo Calhoun data was from within the Bronson system. But the other data, I literally looked at on the web for anybody who was reporting COVID mortality by race. And the 3 that I could find that were particularly relevant were Washtenaw County, where Ann Arbor is, New York City, and Detroit. And then New York and Detroit were from their city health departments and were not being reported at the state level at that time. When we look at this in the same way that we just looked at infant mortality, we can see consistently that the ratio of Black to white infant mortality for COVID was at least twice that for Black Americans as it was for white Americans, and that was consistent really across all the areas that we're reporting this data. Again, our ability to find this data and stratify in this way has improved dramatically. All of this data on this slide came from the state of Michigan site, and where it's very easy to ask this question and get to a meaningful answer. So this is cumulative data through October of 2020 from the beginning of the pandemic, and it's presented and is extrapolated from the state of Michigan website. I think there's some good news here in Southwest Michigan, however, as we look at the ratio of Black to white mortality for COVID in Calhoun County, that's fallen from over 2 to just under 1.5, and in Kalamazoo, just over 1. So essentially, or approaching equality in the mortality outcomes for Black and white people in Calhoun and Kalamazoo County. As I begin to wrap up, I'm going to bring us back to this quote from Don Berwick, and what I've done is I've just made a single word substitution, and I think it's important as we think about the steps we've taken in addressing disparities in health outcomes, but also the distance that we still have to come. So, paraphrasing Dr. Berwick, how far we've come. A mere 5 or 6 years ago, the language of equity, if not the ideas themselves, would have met with blank stares in most quarters of American healthcare. It's not that we didn't believe that equity was necessary, but rather, simply put, we didn't have a plan. I think we're making good progress in having a plan, and it really requires us to have data that allows us to see where these disparities exist, to work collaboratively within health systems, across health systems, and with the community to intentionally and proactively identify and provide equitable health care to close these gaps. Here's a quick example of that work that's happening in our community. This example happens to be from Kalamazoo County, but very similar work is happening in Calhoun County, where important health organizations are coming together to say to our community that it's important that you vaccinate your family for influenza each and every year. And this is seen as us building competencies and partnerships to do the same thing as the COVID vaccine comes to market, hopefully in the near future. And I look forward to Dr. Go's update on that work. At this point, I'll pause and be happy to answer any questions.
Yes, thank you. If you have any questions, you can use the chat or you can raise a hand. So we'll give it a few moments to see if there's anyone with any questions.
Can I
Dr.
ask
Go. Yeah.
Yes, no, Dr. Elaine Davies does a very excellent presentation. One thing that I was very nice to see about the disparity and the mortality rate that in your local area, and I'm sure thanks to Mr. Stewart as well, is that what are some of the interventions that you've seen to do in your local impact community? Because obviously, as you've seen, it doesn't matter if you're in Detroit, New York, or Los Angeles.
Yeah, so fundamentally, I would give Eric and other community leaders, a lot of the credit in that space. So we've been having this conversation very intentionally at the healthcare system and at the community level from the beginning, and understanding that there are disparities in access, and that includes PPE, that includes testing. And so partnering intentionally with organizations that are that target testing or other means of delivering care that's important in COVID in the community. So that's included partnerships with federally qualified health centers across the 3 counties that are our primary service area. And that's been collaboration around testing strategy, co-development of clinical practice guidelines that help us to understand what is the best evidence about how we identify and treat COVID, and ensure that we're generally rowing in the same direction from a public health perspective. It also has been medical partnerships where the federally qualified health centers and our health system have partnered to prioritize together the testing strategies to deliver the greatest impact for the greatest number of people, and to ensure that we are working together to address supply chain issues and testing process issues. More broadly, it is partnership and regular conversations in a way that would happen occasionally prior to COVID, and I know that you've likely seen this in much of your work as well. COVID has been galvanizing in the willingness and the focus by which health systems and other important leaders in the community come together to understand how we, again, deliver the greatest good for the greatest number of people.
All right, are there any other questions?
Yes, I have no idea how to raise the hand function works, but hey, if that's my biggest issue today, then have at it. Thanks, Doc. Great data and great way to bring that key data about our most vulnerable communities together. And I think it's the leadership that you provide that gives the rest of us pause and converts that data into action. And I think you and I have had that conversation before, that the data is great. We can read it all day, but if I think I told somebody, if Miss Jones passes away, we can avoid that. The action we take as a group, as a whole community, is regardless of how you feel about what's going on around you or where you live, can save lives. So thank you very much for that data. I definitely will take something away from this.
Thank you, Eric.
Okay, thank you so much. And I'm not seeing any other questions in the chat, so we will move on to the next presentation. So I have the honor of introducing Dr. Will Go. Dr. Will Go is the Senior Vice President and Head of Development at A2 Biotherapeutics, having acquired major success in drug development at both Amgen and Kite Pharma. Prior to his career in drug development, Will received his BA in biology from Carleton College and then attended University of California, San Diego's Medical Scientist Training Program. He received his PhD in 2004 with a focus on immunology and completed his MD in 2006. Will did his internal medicine residency, hematology oncology fellowship at UCSD. He was the recipient of the California Institute for Regenerative Medicine Fellowship Award and the American Association of Cancer Institutes Fellowship Award, studying tumor immunology. Will also volunteers as a board member for the American Pancreatic Association Foundation and as a board of trustee and COVID-19 task force scientist advisor for Viewpoint School. So thank you so much, Dr. Go, for joining us today, and we're looking forward to hearing your presentation.
Oh, great. Thank you very much. It's my honor and pleasure. Thank you, Mr. Winslow and Angela, and congratulations, Mr. Stewart. This is actually, as you know, this is not my day job. I'm a hematology oncologist, as you heard. And what you can see that I'm here mainly, as you can see on this first slide, that I'm doing this as a volunteer because, as we all know, science matters. And as a physician scientist, we need to really all step up and lean in. And so what I've now going to present is more on the drug development side, but also as a case study about safe school reopening. It's not a choice of on and off. It's more of a dial and what can be done safely. On the left here, I just wanted to go over some of the basic science. It's called coronavirus, as Dr. Elaine Davies has mentioned, because corona means crown, and this the spike proteins around the virus you can see here, as well as what we're trying to develop in terms of a community of physician scientists and scientists, which is either antibodies that can be neutralizing to bind to the spike protein, also ability to then make vaccines to then generate an immune response, both humoral, which is antibodies, and a cell-mediated immune response. And one thing that's really interesting, because a lot of questions come up about children, is that the predominant receptor that the virus uses to invade us is ACE2, and that is typically not on children until past puberty age. And back to the high-risk individuals of diabetes, obesity, metabolic syndrome, that's when you have higher ACE2 receptor, and that's one reason why you think you can get higher risks in those categories. And then I'll then go from the therapeutic side to a message of hope. On the right, you can see that at Viewpoint School, we were the first in-person graduation with testing, tracing, and masking. You can see that on the top. And then my shameless plug, that's my mini-me, Aiden, out there on summer camp. And then how as K through 2 school is open right now at the school. And we'll talk about how to have a safe reopening and stay open. These are my disclosures. Next slide. Okay, next slide. All right, so clinical development trials 101. So phase 1 through phase 4. And this is what we'll get into as we, Mr. Winslow asked me earlier in the discussion about Moderna and others to understand what these trials mean. So the big thing is that phase 1 is what we call dose escalation or safety. Phase 2 is an expansion, looking at safety and efficacy. And then we go into what is the gold standard, which is say randomized phase 3s. So you don't know if you're getting the actual potential therapeutic or vaccine in this case, or a placebo that you don't know about. And this is looking at effects size and for efficacy and safety. And then after you actually have FDA approval, or in this case, emergency use exemption, then you would then look up for observational safety follow-up. The one thing that I wanted to say is that no one is doing any shortcuts from the scientific and medical safety reviews. The clinical trial process is still proceeding in America and by the WHO and warp speed, which we'll get into in a second, very consistently. What you're happening is you're cutting the red tape. So you can think of it like when you go get your passport renewed or your passport line, you're just getting to the front of line pass. So all these trials are coordinated centrally with the NIH, the FDA, drug leaders in terms of pharma and biotech, as well as in the CDC, NIH, and the FDA. And then what is happening is that a lot of manufacturers like Pfizer, like Moderna, are making final product for commercial use or post FDA emergency use exemption approval at risk. That's the main thing. That's what's happening. So we can do a big rollout first. And as most vaccine development, you start off within the high risk ability of folks, frontline workers like physicians and police, fire, and then you go then down. And then with that follow-up data, you'll start seeing more data done in children. Next slide. So one thing first is we call therapies versus prophylaxis, as in vaccines. So therapies. So the first therapy that was really being FDA EUA is Gilead's remdesivir. I used to work for Gilead, so I have a conflict there. But the remdesivir was actually designed for SARS-CoV-1, right? So as Dr. Elaine Davies presented about SARS-CoV-2 virus, it was actually designed for SARS-CoV-1. And that's but it's an IV, it has to be administered in a hospital setting. And there are some liver toxicities associated with that. The second thing is then looked at dexamethasone or just standard steroids. The reason why I got involved early on in the pandemic in January is that, as many know, is that you're getting this cytokine release syndrome. One simple way to think about it is that you have antigenic drift and antigenic shift. So when you see a new virus, and for children, it's just any other like standard coronavirus, so they don't really get an overwhelming immune response. But for us physicians, as we get more and more senior, we see standard coronavirus, the coronavirus, and then we see this brand new one, and it's a new one, and it's a big shift, and then your immune system overreacts, and you get this cytokine release syndrome. And therefore, we know now that with corticosteroids, just like dexamethasone, ability to try to keep people prone, try to then be able to keep it from overwhelming immune response. That is some of the long-term sequelae that you're seeing as well. So the first thing that was starting to happen was we were getting convalescent plasma, meaning people who have had SARS-CoV-2, had infections, had then recovered, and then actually take out their own plasma and try to find antibodies and then create more neutralizing antibodies. And this is what you're starting to see now that's been in antibody cocktails or an individual. Next slide. So the first one that has had the FDA EUA, emergency use exemption, is actually coming from what you can see here. Is you can see it that it's coming from others, just like Lilly, as well as from future. You'll start seeing Regeneron and bamlanivimab, which is hard to say, but it's a monoclonal antibody that will really attack the spike protein. And this is the very first one that has been through warp speed and has been now authorized for clinical use. And this is getting rolled out right now. This is the idea that once you are authorized that you are starting to need to be, because you're hospitalized or require oxygen therapy, that you can get bamlanivimab right away to then prevent you to get you into the ICU. So this will be very interesting as this gets rolled out. I know this is being given in tertiary care centers, and I'll be curious in the discussion if Dr. Elaine Davies, if you have access to this in your local hospital. Next slide. The one thing I've been very proud of other physicians, scientists, leaders in the biotech arena was this COVID-19 vaccine pledge by all these CEOs and biotech leaders from big pharma like Johnson & Johnson, Pfizer, all the way to small biotech like Moderna, Novavax, BioNTech, which is actually part of Pfizer, that the pledge basically says no shortcuts will be done. Phase 1, 2, 3 will be performed. We will continue to have what we call a data safety monitoring board, independent data safety review. And these are all what we call pre-specified endpoints, meaning that none of the data readout you're seeing is actually triggered by any one individual. The data readouts are triggered based on certain endpoints of the study, whether it's efficacy or safety. And that's what then leads to what we call interim analysis, primary analysis, and then subsequent follow-up final analyses. Next slide. All right, so some basic immunology. I don't want to bore you to death with hardcore basic science, but I think it's really important to do some basic understanding. Antibodies. Antibodies are our own ability, a humoral response that are mainly from the B cells to plasma cells. We make little smart bombs called antibodies all the time. And that's what we can do. On the left is a nice little cartoon of showing all the little Y-like antibodies attacking cells, attacking foreign invaders, attacking virus. This is like a cell that has been infected by a virus particle that's being released. And mRNA vaccines are, quite frankly, quite new. So there are mRNA therapies that we tried to use in cancer, thinking we can make an mRNA vaccine for cancer and have not been successful. There are some mRNA therapies approved for rare diseases. And the idea is that mRNA, is the mRNA that these vaccines, like the two positive phase 3 trials that have been reported, are really carrying little bits of the genetic code of the virus, predominantly the spike protein, how you invade. And then we lipid coat it or put it some way so it can get into our cells, but taken up by our white blood cells, especially around more on the macrophage and Langerhans cells. And then it can produce the proteins that can either be presented by the macrophages or dendritic cells, or expressed and then endocytosed and then really be presented to then make antibodies to a humoral. So but it would be either a humoral antibody response or cell-mediated immune response, as you can see here. And this is the thought. Now, I can tell you nothing has been done this quickly in human lifetime in terms of vaccine development. Next slide. So Pfizer's BioNTech, this is the one that has been randomized phase 3 of over 30,000 patients. Next slide. This is a global trial with over 30,000 patients, 15,000 in arm. You can sort of see the timing here. This is from clinicaltrials.gov, how quickly they were able to get going from April 9th to the beginning of July 27th of the randomized phase 3, which is unprecedented in drug development. Next slide. This is from the BioNTech website. but you can see that there's different ways to then take the mRNA and stabilize it. This is the reason why you hear about cold chain supply of -80°C, which is like dry ice, because it's really hard to keep mRNA and liposomes stable. But again, here's a nice, they call it light speed, because Pfizer is not through Project Warp Speed through the government, and they did not receive any United States government funding. This is all privately funded and it worked globally, and you can see how fast they were able to do it and still get to the phase 3 trial. So next slide really quick. So the nice thing is that we are seeing, yeah, go ahead, next slide. What's nice is that, as I was trying to get at, is that phase 3 data is only top line data been reported for Pfizer BioNTech. It says 90% protectiveness, but I want to caution, this is the early readout, meaning that we call it regression to the mean. So with more follow-up, we'll get safety follow-up and we'll get true efficacy signal, or we call hazard ratio, to then see what is the true effectiveness. Because one thing I've always said is a mask, a simple mask, 2 cotton mask, is 80 to 90% effective. And so what Dr. Redfield said, yep, as Dr. Davies said, and if you have a N95 with a face shield, it's over 95% effective, that a vaccine is going to be basically the same effectiveness as a mask. So this is what I was trying to say, is that physical distancing and masking is still just as effective. All right, so now what's the next one that went to phase 3? Moderna. So again, Moderna, you can see the press release from Moderna. They provided a little bit more data that came out today. This was part of what you're seeing in the public literature, and we will get more data as it goes. But they can see now, sorry for the small print, but it's a pre-specified interim analysis once based on 95 cases across both arms. And once they triggered that analysis, they had 90 cases on the placebo arm and 5 cases on the mRNA vaccine arm, which then gives you a point estimate of efficacy of approximately 94.5%, which you can see is statistically significant to 0.0001. The thing again is that what's nice about this trial is that it's randomized phase 3. They've included a lot of folks over age of 65, a Latinx, African Americans, Asians, and biracial. And they really try to then get a good cross section of who's really going to do this. There are some safety things, which like any vaccine, typically similar to influenza with site injection, pain, myalgias. And what we're going to see now is really the follow-up data in terms of the 90-day safety follow-up, followed by the 180-day safety follow-up. And so the idea, is that they're all ready to go with a lot of vaccines produced for potential use. But then we have to then get the safety follow-up before we actually get it through the rollout. Next slide. The third one is the AstraZeneca Oxford Bio one, which was published in Lancet on the phase 2. As an immunologist, you're not going to get away with me unless I produce some kind of really cool interferon gamma slide on the left. That's just my requirement as an immunologist to show. I see Dr. Lynn Davies smiling. And this is just what's really impressive, is it's not only producing and neutralizing antibody, but this is actually showing cell-mediated immune response. This provides me to have some hope, because one challenge thing about vaccines is that if it's just the humoral response, all these mRNA vaccines may require every 3 to 4 month dosing. I'm going to say it again, every 3 to 4 month dosing. The other part about that means is that we don't know if we're going to be in this for a while. Are we going to get a memory response? And the only way you get a memory response is a cell-mediated immune response. And that's what this is suggestive in this phase 2 on the left. So that's where, for immunology geeks out there like myself, that gave me some hope. Again, I'm just going to keep repeating that masks, that can be the way out of this as well with physical distancing. So it's going to be a combination approach of physical distancing. I don't say social distancing because we want to be social, just for physically distant, masks, proper hygiene, small cohorts, and then we get with therapies with steroids, remdesivir, antibody therapies and cocktails, and then vaccines. Next slide. All right, so now for something completely different. I still have my time. You're gonna see a video now, because I realize that I can tell you everything and show you cool, cute pictures like these. But I realize the video is gonna really, and we'll talk on the other side. I apologize, it's 15 minutes. Bear with us, but it's done by a Emmy Award-winning documentary artist, because we're in Los Angeles. Andrea? I don't hear any sound. You're gonna have to do the pass-through sound. You're gonna have to unmute yourself and then do the sound. Sorry, there we go.
Going into summer was scary. We knew we were going to be the test subject because a lot was weighing on summer. There was so much unknown. No one's run a summer camp before in a pandemic. And if they have, it was 1918 during the last pandemic.
At first, it was definitely nerve-wracking. I didn't know what to expect. Obviously, nobody really knew what to expect.
You know, we're getting all these campers who've been cooped up at home. Are they going to have different behavioral patterns that we haven't seen because they've not had that contact with kids their age necessarily, or, you know, gotten direction from a different adult?
Initially made me a little nervous, just because I didn't know what a pandemic really entailed. I knew what it took me to go to the grocery store, and knowing that I would come to camp and interact with kids.
We were worried about how this would look, and would anyone want to come to a camp like this?
I was really skeptical at first. I was like, should I do it? Should I not? But seeing how they were going to approach it really kind of made me feel at ease a little bit, to know that it was going to be structured.
One of our core values, which we embraced as one of our core values for this time, is science, and the notion that this is a public health phenomenon. This is a virus. Therefore, we're going to let the science guide us along with our sense of educational best practice.
We realized that with baseline testing, with distancing, with masking, with hand hygiene, and all of the other safety protocols in place, that it would be possible to run a safe and still fun camp experience for the kids who wanted to be on campus.
The first challenge that we came across running our summer camp was having to unplan our original summer camp that we had planned.
How do we rethink these things that we normally have been doing at camp in a totally different way?
We had 6 weeks planned with field trips and on-campus vendors and, you know, everything that looked like. And when this pandemic hit, well, we needed to cancel everything.
We didn't have any third parties. There were no field trips. We really did everything in-house.
We needed to come up with activities that our campers could do, but yet still be socially distanced. How do we set up our classrooms? How do we include this 3 feet or now a 6 feet space between all of our campers? How do we limit the amount of activities they're going to and mixing with different pods?
The theory behind putting kids in pods or cohorts is so they are exposed to a fewer number of kids per day. Although we can do our best to keep the kindergartners masked and distanced, sometimes there is going to be a little bit of mixing in the classroom. And despite our best efforts, you know, they might get a little too close together to work on a project or to play with each other. But if really only those 10 kids are together every day, that makes it a lot easier to know what's going on in that circle, especially if we also talk to the families and say, these are all the rules that we're all going to be following.
Usually at Coyote, we go to places and we volunteer at like animal shelters, and we go to like food banks and we help, but obviously we can't do that this year. So we've been sewing masks and assembling face shields and making soap for first responders and service workers.
The summer team really bonded and really helped to run a program, and the payoff was having kids back.
Implementing protocols has definitely been probably one of the hardest parts of this summer, but we have a staff that is so willing to do whatever it takes, making sure that the health and hygiene periods are all being taken care of, making sure all the kids are wearing their masks and following the arrows, reminding them of social distance. It really just takes us being present.
It is a lot of extra work.
Having the team we do made it a lot easier.
Trying to navigate what the health protocols are, that's just confusing. But having the task force team, operations, campus safety, everyone try to take this information and apply all these restrictions to how it will look on campus.
The collaboration and the cooperation within the different departments within the community rivals any specialized unit that I've ever worked with.
It's a great team effort to make this place as safe as it can be.
I really liked the way everyone banded together for a common cause, to have children back on campus.
We were able to put together protocols so we can ensure parents, students, faculty, and staff the safe as possible way to have Viewpoint Summer.
The stance that we wanted to take was going above and beyond what the guidance was. And everyone's top priority is the safety and protection of students, faculty, staff, all the employees, parents. It's our mission.
You're talking about people's health and their well-being, and I think that the school takes it very seriously. Graduation and commencement showed us that it was possible. We were able to then translate that into summer programs with our younger children.
One of the things that was most important about the graduation planning and execution was that from the beginning, we saw it as a learning experience for what we knew would have to be a different way of living through this period of time. We saw it as a phase 1 trial, if you will. So we could practice all of the elements that would become part of our daily lives and daily safety and safely operating during this period of COVID-19. The task force that formed around graduation then became the task force that informed our planning for summer and our planning for ultimately reopening school.
We took what we learned for graduation and we just broadened what we did on the field and reimagined at least one half of the campus that we were going to use. And so actually the transition from graduation to summer camp was a lot easier, at least on my end and on my team's end. Once camp started, was like a well-oiled machine. The staff knew exactly where to go, how to go about doing it.
We felt confident that if we were able to do and employ the same things that we did in the graduation phase 1 to the graduation 2, we could keep the campers, faculty, and staff safe.
What we took from graduation into the summer program was the same structure of controlling movement, verifying that the background rate of the virus was 0 before anybody stepped foot on campus. So having that health screening, which would be the next layer, and then having pods.
The parents that did send their children complied with the COVID testing. We did limit how many people could be in a room just to follow those health protocols.
The only times campers are without a mask is 1, when they're outside eating 6 feet spaced apart outside. 2, when they're in the pool. They have lane markers, and we have limited campers per a lane that are more than 10 feet apart. 3, when they're on the field. What are they doing on the field without a mask? Games that you don't have to touch anything.
Opening is my favorite part of camp, being able to see everyone in their spots and see everyone be a part of our community, even though we're a little separated. I think that's incredible.
We have camp songs, we have announcements, we try to make it feel as normal as possible so that it still feels like camp, despite it being with masks and distance.
They know that when they put their arm up, if they're touching someone, they're too close. So they take their steps back. They don't complain at all. They understand that it's all a part of being able to be physically here.
I like to pick up the kids' verbiage because if you use what they're saying, I think it's gonna help them realize like we're all on the same team for this. My favorite thing is arms distance, like airplane, and they do the little like turn.
A typical day includes 5 health and hygiene periods, and that includes washing hands, a mask break, hydrating.
We always wear masks. We keep our distance when we eat food, and we sanitize our hands and wash our hands almost after everything.
The kids are functioning and having fun.
Sometimes we get really cool surprises here, like this day we get to eat pancakes. just for fun. And sometimes we even come to school with pajamas. That's very funny. The Magic Day, he showed cool card tricks and illusions. Even though it was done on Zoom, it was a really fun magic show still.
The summer's been an experiment, and it's an experiment that's going well, I think.
I thought that we'd be very constricted in our possibility and our creativity, but that's not been a challenge at all. I was very surprised coming in about how easy it was still to make those connections with the kids and how we can see so much of their face even without being able to see their mouths and noses. They're so expressive in their eyes, and I thought that they would think that it was strange that they couldn't be right next to their buddies, but they really understand.
What has surprised me the most is it still feels the same. It's still fun. The only difference is you have to wear a mask and social distance and wash our hands a lot. I like it kind of. It's because it makes me feel safer.
What I love most about camp is just the energy that these kids have kept going regardless.
They are happy to wear a mask. They like health and hygiene. They want to go wash their hands. They're very aware of the world we're living in now.
The kids got so used to wearing their masks. They were so accustomed to it. You know, we thought, oh, they're going to have a hard time wearing them. They didn't. They didn't have a hard time wearing them. Even the little kindergartners, and I was pretty surprised by that.
My grandchildren are coming to camp, and I was asking because I had been concerned about the masks and the distance seating, and it has worked. Yeah, it's really good. Okay. It was really good to see them.
I feel safe coming back to school in the fall is because I've seen these rules at camp, and then I hope and I think it's the same that when we come back. And also I think there's going to be not that much kids in each classroom.
The reflex response is already to have their mask on, is already to wash their hands multiple times, but we have the guidance from faculty and staff that have been trained, and then our campus safety, even behind them, constant oversight. And that's what you need in a situation like this.
I do feel safe. I get tested regularly because I do, come to camp and come to school, and I want to make sure everyone's safe.
I feel completely safe. I know the protocols that we are practicing and that we have implemented, and I follow them. I lead by example.
With all the testing that we're doing, all the protocols that are in place, it's evident that what we're doing is working.
I do feel safe coming to work every day, because we do really reinforce, wearing a mask.
When you're wearing a mask and where I'm wearing a mask, we're keeping everybody safe.
I think it is built into the culture of Viewpoint that we do think of others, pandemic or not. Those practices are still taught, encouraged. This is just another way to show them.
The summer at Viewpoint has prepared us to realize we can do this.
We've acquired testing for the campus when needed. We've also had many of our nurses and administrators and myself take a contact tracing course, so we're all certified. So if that becomes necessary, we won't have to wait for LA County Public Health and we can just jump on it.
It's made me very hopeful that there is a way to run school, to have kids on campus in a very managed, thoughtful way.
If we're all starting to congregate back together, it's going to require discipline, but I think it's a challenge that all of us are willing to embrace.
I don't think a lot of other companies, schools have the team that we do behind the scenes.
And we'll take it up a notch with our reconfiguring of the campus, dedensifying the classrooms, putting up canopies so we have additional learning space.
What we're doing now will probably permanently be in place for years to come.
We're ready for phase 3, the fall, the reopening of school.
Viewpoint is ready to open up safely when the county allows us. Viewpoint is ready to provide quality online learning if that's where we are still, at for a few more weeks or months. I would say that Viewpoint has such a good team and has worked so hard that we are ready for whatever the virus or anyone throws at us.
Our graduation was a huge success because summer program was unprecedented, a huge success. Our sports program is online and doing great. All of those are building blocks and a pathway to opening up in the fall, but we don't want to be overconfident. So we've always stayed within the guidance and gone.
All right, I just wanted to end early because there's a lot in there, and I wanted to give opportunity to people to ask a lot of questions. I know Angela, there's a lot of school folks on as well. The one thing that is hopeful to me is that if the kids and kindergartners can do it, us adults can do it. The one thing that's really sad in LA County, because we've been, Viewpoint is a private school with a public purpose. We've been talking to LA Unified, Las Virgenes Unified, Conejo Valley Unified. The sad thing about LA Unified is over 50% of LA Unified children right now are in poverty because of the pandemic. Over 50% of LA Unified parents don't have jobs right now. And, yes, we do have surveillance testing available, but a lot of the things that we deployed at Viewpoint can be deployed very simply at public schools. So we've been working with LA Public Health, LA Unified, and other school districts in the area how to open their K-5 open safely. And they have been with less transmissions than in what you're seeing in the public as well. And so this is why, I wanted to demonstrate that, because as you saw, the kids love coming to school. They love wearing masks. They love doing whatever it takes to keep it safe. And I know we're in Southern California where we have better weather than you all, but you can do it very safely as well in a hybrid situation, where, as everyone knows, the highest risk is eating without a mask. So a lot of the public schools in LA Unified and other places are just doing an AM PM hybrid. So 2 double drop-offs, pickups. So that way they're not eating at school, they're eating at home. And for the lunch assistant programs, you just have everything that's non-perishable lunch assistant sack lunches that they take home on their AM group, or take home or provide or take home as a dinner effectively PM group. So this is what has been happening in a lot of places in California. So with that, I'll open up the questions.
Thank you so much. So one of the first questions we received in the chat was, will the vaccines provide permanent protection from the virus?
Yeah, thanks. I sort of mentioned it briefly, but my opinion is no, because mRNA vaccines and virus in general, you can get the coronavirus, just any coronavirus, over and over and over again. I don't see why this would be any different for SARS-CoV-2. The second thing with the vaccine is that the way these vaccines work, you might only get it for immunity for maybe 3 to 4 months. You might have to get redosed. We don't know how often you're going to get redosed. And so this is why this virus will be around with us for a while. It's a marathon. I know there's a lot of COVID fatigue and pandemic fatigue. So it's a marathon, not a sprint. And this is why what I'm hoping is, with additional tools in our toolkits, we have masking, we have physical distancing, we have cohorts, pods, and then once we have therapies, that we can then get to a point where the background rate, and hopefully then next year, Dr. Elaine Davies will show me great data from your county showing that the death rate is just basically the same as any influenza year.
Thank you. We had another question come up and asked if you have a comment on the Great Barrington Declaration.
What's the Great Barrington Declaration? I'm not aware.
I'm not sure.
All right. Yeah, I mean, all I can say, one declaration I can say, which I've said very publicly, public health and politics should never mix. I want to say that again. Public health and politics should never mix. Dr. Tony Fauci, I know personally. My dad was at an NIH. I'm a Mayo kid, as you heard, Carleton College, because I was born in Rochester, Minnesota. So I know what it's like to experience -20 Fahrenheit weather. My dad had served under Ronald Reagan with Dr. Tony Fauci, with Ronald Reagan at NIH. Dr. Fauci, Tony, is 79 years old. What I've been really proud to say is, under the Reagan administration, HIV is not a gay disease, and without the Ronald Reagan administration, HIV would not be controlled the way it is now. And so what is what all these institutions that, you know, I hold dear with the NIH, FDA, and CDC are here to protect us. And as it's very similar to NATO, that we should be fighting pandemics in other people's soil. And so when we have these pandemics, which happen every 5 to 10 years, you know, H1N1, I was still practicing at UC San Diego when that happened. Ebola, I mean, this is a bad, you know, sequel, SARS-CoV-1, SARS-CoV-2, you know, Dr. Lane Davies, I know there could be SARS-CoV-3, you know, it's a matter of time before you start seeing this. And as we become more of a global society, we will see more and more of these zoonotic transmissions from other areas as humanity spreads out across the globe faster and faster and faster. And so the only way we can do this is together with science and public health. And what is always amazes me is the children, these kindergartners that you see on the videos, and my kids who are just, you know, just turned 10 and almost 12, really understand how to keep everyone safe. We have not seen transmissions at Viewpoint School. You know, that's amazes me. We've logged in over 5,000 negative tests. And we have had cases, just like as Dr. Lane Davies says, the background rate in LA is not low, it's quite high. But what we do is that with testing, tracing, masking, physical distancing, we're actually preventing it because we're basically doing universal precautions at school. Herd immunity is a good question. So herd immunity is an immunology concept where if everyone has immunity, then that way you sort of protect the herd. You only get about herd immunity until you get about 80 to 90% immune. You start seeing sometime around 60, 70. So the only way to get herd immunity with this vaccine is literally 80 to 90% vaccination rate. The sad part about influenza, seasonal flu, and I don't know your local area, but the seasonal flu only still sees about a 60% vaccination rate in the country, 60%. In the state of California, certain vaccines like measles, mumps, rubella is mandated by law to come into public school. And that's why we don't see measles, mumps, and rubella in public schools or any school, quite frankly, in California. But we see a lot of influenza A because of the lack of vaccination. And so the challenge right now is that we need to start educating now, especially in places of poor social economic class and in minority populations and people of color, is that we need to ensure everyone that vaccines, about the safety about these vaccines that are going to roll out. What is very interesting is that there's already been epidemiology reports in California where the people that don't want to wear masks are different than the people who don't want to get a vaccine, which means that that's not good because you need to have, to be frank, if you get 80, 90% masking rates and 89% vaccination rates, you would be able to contain this virus from a public health and epidemiological standpoint. There is a false representation that if we all get SARS-CoV-1 or SARS-CoV-2 or any coronavirus, we can mount herd immunity. That is not true. Chickenpox, that's different. You can do because it's a one and done thing. The problem is that they're already seen in Asia, in China, in South Korea, in Japan, in Hong Kong. You're already starting to see people getting reinfected again from SARS-CoV-2, getting COVID-19 again. These are great questions.
Okay, so are there any other questions from the group?
Dr. Go, this is Lane Davies. Really appreciate your presentation. The blending of the sort of power of public health with rational use of the best evidence is really impressive. So I would applaud you and the school in the way that was executed. We're seeing the same thing here in our healthcare system. The infections are not happening when people are mindful and aware of this. This happens when we let our guard down and either choose to or unable to follow those physical distancing rules for whatever reason. curious about the contact tracing program that the school implemented. Are you able to share any more about that? It's a really interesting approach. Our public health departments are overwhelmed. The nurses in those areas don't have enough hours in the year, let alone in the week, to do the amount of contact tracing that would be necessary from a traditional public health perspective.
No, that's a great question. So in Asia, for example, they're using these. We have powerful tools to do contact tracing, but in our society, it's effectively a civil liberty reason why we can't use phones. So we have to then do manual, right? So in a perfect world, we could just use phones, quite frankly. Okay, so what we're doing is that, and this is why we're informing other public health, public schools, there is a free contact tracing program at Johns Hopkins. You know, in the Johns Hopkins pandemic for health safety, you can take it. So what we started doing is getting a lot of the administrators, teachers, you know, whoever you can find. I mean, you can, quite frankly, it's designed for a 5th, 6th grade level. We were talking, we can even get the seniors involved, the juniors, right? People who are pre-med or, or the ROTC group. They're actually wanting to take these contact tracing. It's not that hard, right? And what our head of campus safety, who used to be, who trains former LA SWAT, it's a force multiplier as we talk it. You know, you can think of it as physician extenders. And so what we've done is we've gotten other people to get the contact tracing. So to your point, Dr. Lane Davies, is that once we see a positive case, we don't wait for public health. We're doing the contact tracing already. And then we're the ones that are reporting to public health who's quarantined, who's not quarantined, who's isolated, who's not. And then we have capacity at LA Public Health testing right now. If you want to get a test, you can get a test in LA County, and that's free. We also implemented through Dr. Tanya Altman, who's a parent and local pediatrician. Her office is nearby, so we do have antigen tests that if we do have symptomatic patients or students or teachers that became symptomatic after temp checks and everything, that we can send quickly to then see if they actually have it or not. So we've really deployed all of these systems to do that. The interesting thing is K through 5 or K through 6, depending on how it is easy, because you know your pod is your classroom. Middle and upper school, when you do the math, you're talking about, like college, you're now talking that one positive case could track up to 80 to 90. One positive case can track to 80 and 90. So we haven't opened middle or upper school yet. We've done sports and band and robotics type things, but those are still cohorts of under 25. You know, usually we're mandated cohort at 12 actually in LA County. But what we're trying to do, to your point, is we are now going to start deploying for middle and upper, if we can go open the high school, is assigned seating with barriers. So that way, when you do assigned seating and barriers, you can then do contact tracing appropriately. And same thing with the lunch period, right? You sort of eat lunch in your own seat. The other thing that we're trying to get operational is pooled testing. So the way to get costs down for public schools is to do pooled matrix testing. So you can do a self-administered swab, put it into a guanidine VTM, have it there, and then do regular pool testings. And if you pool test every week, you do the back end calculation with the rates, what you're seeing in your local area and ours, you should be able to then have a reasonable surveillance testing regime. And that's what we're trying to get up for the winter as it gets closer and closer. I do want to answer one good question in the chat about some local providers are treating COVID patients as outpatients with a mix of zinc, prednisone, hydroxychloroquine, azithromycin, and antiviral that I don't know what that is, that's standard care. I'm not a practice physician, but it's no. I can tell you straight out, it is no. The data is actually very robust now. Sadly, the hydroxychloroquine was investigated early because of preclinical data coming out of Asia. And there was a well looked at VA study, which showed that sadly, VA patients that took hydroxychloroquine versus not actually had increased risk of mortality, as hydroxychloroquine is actually contraindicated because it causes QT prolongation syndrome, and that is clearly the case. Prednisone is actually not also, that's not studied as dexamethasone. It's only indicated for people who are now going to the hospital and need need oxygenation. I don't know, Dr. Elaine Davies, you want to also comment on that since you're practicing and I'm not?
Yeah, so the answer is no, very clearly and emphatically, that is not the standard of care. No. We, locally, we have a team that has been meeting since the beginning that includes, our pharmacy folks and infectious disease and practicing physicians in the inpatient, outpatient setting. We continue to look at, all of these therapies. And we were involved with some of the early remdesivir trials and in agreement with Dr. Go that team of local experts has been very clear that this is not the standard of care. And probably more importantly, these medications can have, serious side effects. And so if there is no benefit, we are potentially doing more harm than good in that situation. So would strongly discourage people from going down that path.
Great, thank you. I think we have one more question. Are we to expect to use masks essentially forever as not only a tool today, but to stay ahead of future viruses?
Dr. Elaine Davies, you want to take this one first and then I'll give my thoughts.
Yeah, so this is really interesting, right? Because as a pediatric hospital, as somebody who takes care of children in the hospital, physical distancing is good for stopping all viruses. And so, we've had a very quiet spring, summer, and early fall, and are not seeing the same number of the normal viruses that circulate in our community. And so some manner of improved physical distancing and attention to hand hygiene and basic infection prevention approaches are good for stopping other viruses in addition to SARS-CoV-2. As Dr. Go, I think has said repeatedly, getting this dialed in a way that is sustainable, that allows us to go about our lives, but really protects the most people is part of the journey that we've been on. And I think we'll benefit from those learnings that we've had.
Yeah, I go by benefit risk analysis, right? So for example, when I was a kid, I didn't wear a seatbelt. I was stuffed in the back of a, Buick Century Brady wagon in back of a truck, in Minnesota in -20 weather with some blankets, going from Rochester to Minneapolis. So that's a good example where now seatbelts are now commonplace, right? And now if you go look at these amazing car seats for children with 5-point restraints, I mean, they're safer than the adults in the car, quite frankly, because we only use 3-point safety harnesses. The thing that I would look at is that I look at it from a global standpoint, which is very interesting, because one thing that I always remind people in America is that other countries have done much better and with less than we have, okay? And the reason why is because of some of these basic things, and society does change and does adapt. So for example, now, my friends in Europe, especially in France, that double kissing thing is going to probably go away forever, which a lot, for people on some like the call, like Andrea and I, who do global trials and we go to Europe, I hated the fact that I had to kiss every single investigator. So if Dr. Lane was running my trial, I'd be kissing Dr. Lane on the cheek, and I'd be kissing the sub PI on the cheek, and it was like out of control. So that's going to disappear, for example, right? Now, if you go to look at Asia, because they sadly had SARS-CoV-1 and other H1N1 had a lot of mortality. And that's why you see I'm American-born Chinese, that in Asian cultures, masks are pretty much standard. So now when I go, even before the pandemic, and you go to Beijing, Shanghai, the air quality is pretty bad, and sort of like a 2-for-1, right? In California, we have fires. So I always say it's like, most likely, I have a feeling that you're going to probably have a nice mask, charcoal filter mask, N95 mask, KN95 mask, because in California, there's fires, air quality, Beijing, Shanghai, or you're going to go on a plane. So I think what you're going to start seeing is, it's about your benefit risk tolerance, but you're going to a crowded plane for a couple hours, or you're on a bus, you might see people pull out their mask. That's the other thing I wanted to say. It's hard to prove a negative, but if you look at just simple mask wearing, and it's on the CDC website, as well as other governments like Germany, France, UK, Japan, South Korea, just wearing a mask in crowded buses and trains, you're not seeing outbreaks. Just wearing a simple cloth mask or a surgical mask or any kind of mask on buses and trains, you're not seeing transmission. And that's why I think that to that question, that's what someone asked me, I would just have it in your backpack, have it back in somewhere, your pouch or your purse, and then you would just break it out when you were in a very crowded area. I think that's what you're going to start seeing.
Great, thank you so much. And I just want to take this time to thank all of our speakers and folks that helped to put this presentation together. There we go. So if you have any questions following today's presentation, you can reach out to me directly, and we are recording today's presentation so we can share that with you after the event. But thank you for all of our participants as well, and everyone who tuned in to today's webinar, and I hope you all have a great evening, and don't forget to wear those masks.
And Mr. Stewart, I want to say congratulations again.
Thank you, sir. I appreciate it. Keep doing the good work and enjoy that weather out there.
And Angela, you didn't tell me you're related.
Yes.
Yeah, thanks, Doc.
No, you guys are, I'm just telling Angela and Eric, you guys are killing it out there. I'm really loving that what you're doing. So please, please, please keep it up. I don't know how to overcome the issues we're having. And I mean, LA is a classic example. I don't think we should have a problem in LA, but we're having a huge, huge problem in LA because of the disparities you're seeing. And it's like, it is sad. And you just go look by zip code, and it's just shocking. And I think the challenge right now is that we don't have people like you both and the community leaders trying to take the mantle, because it's just, that's what it's going to take. It's going to take literally person by person, community leader by community leader, you know, school by school, church by church. I mean, you name it. It's just unreal. So I think, you know, congratulations to you both.
Thank you.
Yeah.
Appreciate it.
Thank you, Dr. Go.